You are most welcome, ladies and gentlemen, to your power behind a voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, before I take you through what I have for you today, I want to remind you that today is, of course, October 15, and it marks the World Anatomy Day. Now, if you want some bit of information regarding what I've said previously, okay, towards the celebration of the day, yes, you can get to my playlist of course, introductory anatomy, or get to the playlist of important information. My friends, today I take you through Klumpke's palsy, or the full name is actually Dejerine-Klumpke palsy. Okay, so you can get that video link and of course watch it. Now, one thing I want to tell you, yes, as far as the Klumpke's palsy is concerned, yes, unlike in the case of Erb's palsy, where we said that it is very common as far as injuries to the trunks of the brachial plexus is concerned, that of Klumpke's palsy, it's not really very common. It's quite rare, but my friends, it can happen even due to that kind of poor delivery, okay, by the health professional. But my friends, one important thing which I want you to become aware is that this time around, it occurs or it happens to the lower trunk of the brachial plexus. We said that in the case of the Erb's palsy, it occurs to the upper trunk of the brachial plexus, and we said it's due to that kind of, sudden, sudden downward traction to the upper trunk of the brachial plexus. Okay, like that kind of adduction, okay, as far as the shoulder joint is concerned. But my friends, in the case of Klumpke's palsy, is due to that kind of sudden or hyper, abduction, okay, as far as the shoulder joint is concerned, hyper abduction. So this time around, we are talking about upward traction to the lower trunk of the brachial plexus, okay, now of course shoulder and neck region. And so it can lead to something that I can say that we call it avulsion of the nerve, okay, said that yes, the nerve will rupture, okay, at the level of what we call the spine. Or it can lead to a simple rupture where, of course, that kind of tearing of the nerve doesn't happen at the level of what we call the spine. Okay? Or it can, this injury, yes, manifestation of it, which I'm going to describe to you, can be due to something we call neuroma. Okay? And in that case of neuroma, yes, the nerve got severed, yes, healing has taken place, but because of the presence of scar tissue forming around the nerve, it puts pressure on the fibers which are supposed to transmit, the signals to, of course, to a muscle, or to, of course, to give that kind of sensation to a skin. Okay, so another thing too that can happen, okay, is something that we call neuroplasia. And in case of neuroplasia, is due to, of course, sudden stretching, not necessarily tearing, but stretching of that nerve. So yes, it could be temporary, and of course it resolves, faster compared to these ones that I've mentioned. Okay, so that is one thing I want you to become aware of. Now, commonly, what we see is that, for instance, if someone is falling from a height, okay, and decides to hang on to, branch of a tree or a building, then what will happen is that there could that kind of hyper, abduction, or that kind of, upward traction, okay, to the upper trunk of the, lower trunk of the brachial plexus, leading to this injury. Okay, so that is one thing which I want you to know. But my friend, the good news is that, yes, in a year, okay, going through the right, therapy, what will happen is that at least 92% of such individuals may recover. Okay, so that is one thing that I want you to understand. Now, so when I talk about this Klumpke's palsy, the first thing which I want you to understand is that what is going to be the manifestation. Okay, so the classic manifestation that we are going to see is something we call complete claw hand. Yes, there will be clawing of the hand. In Klumpke's palsy, the first thing I want you to become aware is complete clawing of the hand. And what do we mean by clawing of the hand? Yes, this is how it will be like. Okay, because my friends, one important thing what I want you to understand is that whenever we talk about lower trunk of the brachial plexus, the contributions are coming from, of course, C8 fibers and, of course, T1 fibers. Yes, importantly, I'm talking about, of course, by way of the roots C8 and T1. I'm talking about the ventral rami of the spinal nerve C8 and, of course, T1. Okay, so that's one thing I want you to understand. And these ones are supposed to give supply, okay, to the intrinsic muscles of the hand. Importantly, I'm talking about lumbricals. Now, to understand the clawing of the hand, think about the role of the lumbricals. Now, if the lumbricals are not getting the fibers from T8 and T1, then they cannot function. And so what's the natural role of the lumbricals? The lumbricals, L1, L2, L3, and of course L4, okay, what are they supposed to do? Upon their contraction of the muscle, is supposed to cause, at the level of the knuckles, which we call the metacarpophalangeal joint, is supposed to cause what we call flexion at the metacarpophalangeal joint upon contraction of the lumbricals. Okay, and of course, extension at both the proximal interphalangeal joint and of course the distal interphalangeal joint. Okay, so if the lumbricals are not getting the fibers C8 and T1 to give the motor supply, and therefore they cannot work, then the opposite is going to happen. So the opposite is said that at the level of the knuckles, the metacarpophalangeal joint, there's going to be not flexion, but rather extension at the metacarpophalangeal joint. So that at the level of the interphalangeal joints, it's not going to be flexion. Sorry, it's not going to be extension. It's not going to be, it's not going to be extension. There's a normal thing, extension. But this time, right, it's going to be what we call flexion. Okay, flexion at both the proximal and distal interphalangeal joint. And that is what will manifest as clawing of the hand. Okay, I want you to understand this. And that is why I tell people that one of the simplest way clinically, okay, the prosthesis that could be applied to, of course, correct this clawing of the hand is going to be a knuckle bender splint. So that, of course, we put that splint in here, then what's going to happen? Instead of causing this extension, it will bend it, and bending is, of course, flexion. Okay, so that, of course, it will help in, of course, managing this, total clawing of the hand. That is one unique function which you are going to see as far as the lumbricals are concerned. And therefore, if there's injury to afford the lower trunk of the brachial plexus, the fiber C8 and T1 cannot give supply to these lumbricals, and of course, the clawing of the hand will take place. My friends, this one is by way of motor supply. Motor. But is there any sensory deficit? My friends, the answer is yes. There will be sensory deficit. To where? Now, last time I told you, as far as the Erb's palsy is concerned, we said that there will be loss of cutaneous sensation towards the lateral aspect, of the arm, towards the forearm, towards where, of course, the thumb is. That's what we say, lateral aspect. Now, as far as the lower trunk of the brachial plexus is concerned, it's not a lateral aspect, but this time around, there will be loss of nail sensation towards the medial aspect. The lower aspect of what we call the arm, okay, is taken care of, okay, by, of course, T1 and of course C8 all the way here. Okay, I want you to understand it. Towards where the pinky, the little finger is, the medial aspect of the forearm, toward the where the pinky is, toward the, as far as that of the lower aspect of what we call the arm. Okay, so that is what we are going to see. My friends, oftentimes what we encounter in our reading is that, this Dejerine-Klumpke palsy can lead to what we call, or will lead, almost always, will lead to what we call Horner syndrome. Okay, one thing that I want you to understand is that it is not always. Now, when there's that kind of injury to the lower trunk, sometimes, okay, the T1 fibers, they are spared. Yes, I want you to understand that. Sometimes they are spared, okay, and therefore you may not see the classic symptoms of the Horner syndrome. But my friends, almost always, that's what I said, almost always, the T1 fibers will be involved. And my friend, you know that the T fibers, they are sympathetic fibers. Okay, so sympathetic fibers, okay, what this T1 is going to do will be impaired also. And that's the classic signs of what we call the Horner syndrome. Apart from, the clawing of the hand and loss of cutaneous sensation to the lower aspect of the arm. And so what is this Horner syndrome? In Horner syndrome, one thing that we see is that there will be something we call anhidrosis. Anhidrosis. So the person may not be able to sweat, okay, especially in the face region, not be able to sweat over there. So that's the anhidrosis that we are going to see. Okay, that is what we call anhidrosis. Now, number 2 is going to lead to something we call meiosis. Meiosis. Now, the meiosis, what we mean is that, yes, the pupil, okay, will, what do you call it, will constrict. There will be constriction of the pupil. Meiosis is going to take place. Okay, because in situation, the sympathetic fiber T1 is supposed to cause, madrasis Okay, dilatation of the pupil so that more light can enter, so that if there's any danger, you can escape. Okay, so that is one thing I want you to understand about it. Now, the third one, which I want you to know, is, my friends, something we call loss of ciliospinal reflex. Loss of ciliospinal reflex. Now, at the level of the nape, okay, the skin over here, the nape, what we expect is that if I put my finger over here and I touch this area, it's supposed to cause mydriasis, dilatation of the pupil. But my friends, because of this Horner syndrome, okay, injury to the T15 separated fibers, then of course, even when I touch there, there's no reflex, okay, causing, mydriasis of the pupil. Okay, that's the loss of ciliospinal reflex. My friends, the other thing I want you to know is that it will also lead to something we call enophthalmos. Enophthalmos, not exophthalmos, enophthalmos. And my friends, the situation of enophthalmos, okay, that is something we call sunken eyeballs, not protruding eyeball. I'm talking about sunken eyeballs. Okay, sunken eyeballs. Okay, that one will also be evident in situation of Horner's syndrome. My friends, this is what I want you to understand as far as the injury to, of course, the lower trunk of the brachial plexus is concerned. Unlike the situation of upper trunk, where of course we said that some nerve by way of, I mentioned the suprascapular nerve, I talked about nerve to subclavius muscle. In the case of the lower trunk, neither the middle trunk are we going to see any nerves emerging from these trunks. My friends, I'm very grateful for your time. This, of course, this evening, have a good night, all of you, and may the good Lord richly bless you. Amen.